Okay, I must thank Care Group for giving me this opportunity to share my fair experience with the IPCLs. I think I've used a fair number of these, if I'm not wrong, probably highest I've known. And I've had my shares of issues with the design to start with, but I think by now the thing is stabilized and it's just perfect. We all know there are innumerable options available now as compared to a few years ago in the phakic segment. I'll have to go fast because I have to leave some time for the following speakers. The best thing about the lens is the design, the way it contours up, the way it takes in the high vault and the low vault. I have cases of very high vault up to 1200 microns, and the patients are doing well. I've even had case where the patient had suffered a tennis ball injury and the vault had gone down due to some trauma and the zonular loss. The vault was 110. The patient was working for nearly 8 months before he saw me, and there was no cataract. So that goes a long time for the design and the centraflow hole. Let the numbers speak. Approximately, I think nearly 1200 plus. This is a slightly old slide. 124 of model V2. I've done piggyback, pseudophacus, corneal scars, post-traumatic cataracts, clearless extractions, piggyback in patients operated elsewhere with multifocal lenses, with residual refractive errors. So I've done all. Name a thing, I've done all. I put IPCL in practically everything. Astigmatic correction to 11 diopters I've done. I've corrected till minus 34 diopters of myopia. And the best part is I've taken care of pupil sizes up to 7.8 millimeters. I don't think there's any lens in the world which can tackle that. And I think the credit for that goes to the creative and the R&D team with the Care Group, because they actually giving us the muscle to the Indian ophthalmologists to tackle these cases, which I'm sure will be said no to in a lot of other places. The design is very, very typical. If I can use the pointer, there are 6 holes here and there are 2 pointed holes here. There's a unique design of the haptic pad. This haptic pad can actually take in a lot of compression and will still not vault. And even if it is on a lower vault, it still rests beautifully. And the central hole, which is again tapered, will not give you halos. I have incidents of explanting ICLs because of halos. The patient is absolutely emmetropic, but he had halos. So I've explanted them and put these lenses, and the patients are happier now. This is a subset of 300 last patients. The Care Group asked me to do a study on them. I was just doing high volumes. I was not following them up. I started doing a study. If you actually see, majority of lenses are 12.5, nearly 97%. But yes, I've got even small sizes. Our experience in numbers, again, this has gone back. Okay, now, vault patterns, only 7% was shallow vault. If you see, most of them are lying within 400 and above 750. Even 750 microns and beyond, the lenses are behaving beautifully. Post-operative 3 weeks onwards, if you actually see, this is the net result. Now, some of these patients are high myopes and they're amblyopes. So don't look at frown at seeing 618. This 618 probably is the best vision this patient ever saw. A girl with minus 31 or minus 32 and chorioretinal degeneration, macular degeneration, what will she see? But this is what has transformed her life. I'll show you some photographs as we move along. High refractive errors, what have we done till minus 32? Moderate refractive errors, corneal scars, astigmatism, 11 diopters, exceptional corneal sizes, we'll see some videos. We also have presbyopic lenses. We have presbyopic lenses to correct patients who want near glasses. What I've done is I actually feel there's a new category opening for all of us. Any cataract patient you operated 8 years ago, he comes back to you, and now he talks to another person where you put a multifocal lens, and he says, Doctor Sahab, usko to paas ka bhi dikhta hai, why not me? So you say, okay, I have offer something you. When I operated you at that time, this technology was not there. I can offer this to you. You can put in a presbyopic secondary piggyback IPCL in these patients. Not to mention, there's another technique called the add-on lens by Care Group again, but that's another topic by itself. Post-cataract refractive errors. Now, I'm going very fast. This is the leading mark. These are the holes which need to go superiorly. This is the toric alignment. The best part about this lens is you do not need to dial this lens. Read my lips. You don't need to dial this lens. Just mark 0-180, put the lens in, and that's it. No need for secondary marking or secondary rotation. And I feel in my study, the best, most happy patients are patients with high astigmatism. You can imagine you have a patient with 6 diopters of astigmatism and you go off mark by 10 degrees. this patient is going to hate you. But what if your marking was accurate and the lens manufacturer was actually accurate to the last degree? Once you put this lens, this patient's life transforms. The quality of village. This is one thing which was wrong with the ICL. There was a straight cut was causing diffraction. What they've done is tapered the cut on the side, so it reduces the diffraction and increases the aqueous flow from behind into the funnel method. I'm going very fast. The compression pad. The best advantage with this lens is you will get 2 lenses with each order. In case, God forbid, you drop one, you crack one, you break one, and the patient is on the table, you don't send the patient back. So the company sends 1 extra lens with you, which you can return back to the company, and it adds to the company's inventory. So next time you need a similar power, it comes within 2 days. I think that's a wonderful idea. It needs a lot of thinking to think like that. Marking. Now this is what you do with the IPCL. You just align it 0-180 and that's it. Nothing to do. This is 4 years post-op, perfectly aligned, 0-180, no dilatation, no rotation. Advantage of a non-animal source, 6 pads, 4 micron into 3 times the hole. So the amount of aqueous flow which is coming, you see most of the time the IPCL or ICLs were being blamed for coming in contact with the anterior capsule and causing cataract. But studies are coming in, it was more of aqueous stasis between the IPCL and the anterior capsule which was causing the cataract. So if you have the aqueous flowing through, the incidence of anterior polar cataract is 0. In my study, we just had some traumatic cataracts and some patients where I put an IPCL after 3 years, high myopes, they had a retina detachment surgery, post silicone oil, they had a cataract. These are the only cataracts I have to report. Now, again, I'm going very fast, sir. I hope I don't eat into the time of other speakers. This is what you do. You put in a viscoelastic, and that's the beauty of the lens. The lens unfolds so beautifully, so softly, and all you need to do is align the lens, 0-180. These are the marks you need to align. This is my 0, this is my 180. You align the lens, and it's ready to go. There, the surgery is over, and we'll see now one or two tricky situations. Again, I won't go. You have large sizes lens, -17 with -2 diopters, both eyes operated, -27 with -3, both eyes operated, -15. 2 twin brothers, one got operated. He was so happy. The younger brother was afraid. He said, "Pehle iski karao, tab main karaunga." So when this guy got him for the next surgery, -12. So this is again. This girl had retina detachment after 2 years in the other eye. This was the one I was talking about. -29 with 2 diopter cylinder. Now this is again a lens manufactured again specially for us at an 8.5 millimeter. You'll have to see the actual optic to believe it. See the size. Which company can manufacture this lens for you? Only Care Group. I have no commercial interest, please. See the size of the optic. This patient was actually any other phakic lens you would have put, he would have had glares and halos. Another part is the material is so beautiful, it can be so easily withdrawn and put back again. You see, I put the lens wrong side accidentally. I had a new OT technician who loaded it wrong, and I realized it's wrong. I just go in and it rotates. I'll also show you an explantation. Now this is a patient operated Symphony somewhere else. He had a +0.5 residual refractive error, and what do I do for him? I had a choice of either explanting the lens. Last 2 years I've stopped explanting any lenses. Any refractive errors, just pump in an IPCL on top. Because the lens is around 80 microns. Post cataract removal, the anterior chamber depth is anything between 4.2 to 5.7 millimeters. You have a good open angle. You can push in an IPCL anywhere you want. So this is what an IPCL does. This was a very high premium patient operated by one of my friends in Delhi. The lady was very unhappy. The surgery was fine, but there was some refractive error. And this patient is 6'6". This is what you can do with the technique. Another patient post-traumatic operated 17 years ago. He landed up with -17. Very interesting situation. I'm sure none of us would think of even explanting this lens. Completely fibrous with Sanique. So what do? I go in, I cut the Sanique, cut the capsule, a -17 IPCL I put in a patient operated 17 years ago. And you will also see the corneal scar in this patient. He had an astigmatism. There, this is the corneal scar you see. And I push in an IPCL, patient touches 6'9". This is the patient post-op. Oh, it jumped. Yeah, this is the patient post-op. Now another patient with corneal scar. Again, huge astigmatism. I'll just jump very fast, sir. You have to see the corneal scar. This is the corneal scar. 11 diopters of astigmatism. Either you do a keratoplasty for this patient, what else can you offer? This patient is 6'12". We do a 11 diopter cylinder with minus 3.5 sphere. Again, corneal scar, I'll skip the video. Corneal scar, minus 5 diopter cyl with minus 4 myopia. Small scar. This patient again improved. So majorly no explants. We had these kind of situations. We have 297 volt, 848, 1008 volt. No issues with the patient. In case you feel there's a cataract happening, wait. This could be a retained viscoelastic. This is what you see. 4 days afterwards, it starts clearing up. So this is not cataract. This was probably retained viscoelastic behind the lens, which you forgot to remove. Progressive lenses, we've started doing in, I'm going very fast. Progressive lenses, presbyopic lenses, IPCL for your pseudophakic patients and patients in presbyopic age group. I think I did well, sir. I skipped a lot of videos. Thank you.